Okay, welcome everybody. Fiona, are you still live?
Yes, I am.
Great. Maybe I can do a brief introduction to you and then we can flip-flop. It's my pleasure to introduce Fiona Kabagenyi. She's a pediatric ENT from Uganda and is spearheading this lecture series on pediatric aerodigestive care. So I will hand it off to Fiona to kick off the series.
Thank you, Dr. Lia. Dr. Lia Stevenson is, Jacobson is also a pediatric ENT and a director of CHESA. And this is our project that we're working on together. So without further ado, I would like to welcome all of you to the Pediatric Aerodigestive Lecture Series. We're extremely excited about you joining, and we hope that we can have community connection and collaboration as we enhance the future of our pediatric care. This series will bring together multidisciplinary experts from around the world that will share knowledge and discuss innovative treatment strategies and foster partnerships that will hopefully improve the outcomes of our children with aerodigestive conditions. And we hope that this shared experience will create stronger and more connected healthcare community. Our sessions will be via Zoom as it is today, starting today, the 18th of September, and will happen every 2 weeks. And we'll start with the otolaryngologists, but we also have up next people with pulmonologists, gastroenterologists, pediatric surgeons, speech and language therapists, anesthesiologists, and even other people, possibly family, that can actually talk about their experience. Kindly note that the time is actually 7 p.m. for East Africa, not 8 p.m. Sorry for those that I distributed the 8 p.m. flyer. We do hope that you can learn a thing or two while you're listening into this lecture series and that it can actually translate as improvement in your practice. And without further ado, we will start with a few things for the view from the pediatric otolaryngology. And just as a way of introduction, I'll just share some cases from what we have in Uganda. But Dr. Lia, who is from an established pediatric aerodigestive center, will take us through especially bronchoscopy, laryngoscopy, tracheoscopy, and some of the endoscopic interventions that they do in her center. So thank you very much. We hope you enjoy being here with us today.
Good evening, good morning, good afternoon, wherever you may be in this part of the world. My name is Fiona Kabagenyi. I'm a lecturer in the Department of ENT at Makerere University and a CHESA fellow this year. And I'd like to talk to you about collaborative care to enhance pediatric aerodigestive management with multidisciplinary insights. Pediatric aerodigestive conditions can occur from conditions such as foreign bodies, congenital lesions, traumatic lesions, or neck masses, and these present with respiratory and gastrointestinal challenges, which can be difficult in breathing, stridor, recurrent cough, trouble swallowing or choking, failure to thrive, and voice changes. These patients tend to see very many single specialists, and cases of chronic, severe, or worsening airway or digestive symptoms require a multidisciplinary approach. And these may include pediatricians, pulmonologists, ENTs, speech and language therapists, surgeons, among others. The inaugural documented multidisciplinary team or aerodigestive program in the world originated at Cincinnati Children's Hospital in 1999. And currently, as of a survey done in 2017, there are more than 50 centers in North America alone. At least more than 10 are in Europe and Australia, with budding programs in Asia, and Africa only has one in South Africa. A study at Johns Hopkins to determine if interdisciplinary pediatric aerodigestive care reduced healthcare costs over 3 years got an interesting finding, and 125 patients of these 97 was seen at least once. Averagely, 2.9 of 4 consulting services was seen in one sitting, and the most common specialists that were seen were actually ENTs, followed by gastroenterologists, then pulmonologists, and then SLT. 85 of these patients had a requirement for examination under anesthesia, and a total of 267 operations were done. The operations were mostly ENT-led, followed by gastroenterology. If you combined all the procedures that were done, this would actually reduce preoperative and postoperative care by 2 hours. There was also 20 minutes of anesthesia induction and recurrence that were actually reduced from the combination of the procedures. Additionally, 1.9 trips were reduced to the clinics, to the outpatient clinics, and saved the patients $180 per patient. So for our Ugandan context, we reviewed 4 cases from Mulago National Referral Hospital, which is the biggest hospital that we have, and some private hospitals, where collaborative care that involved at least 2 or more specialists was involved in complex aerodigestive conditions. So our first case had maxillomandibular dysplasia and presented at 5 months with gradual swelling of the mandible and maxilla with inadequate feeding, but no stridor. Initially, they had seen an oral maxillofacial surgeon and anticipated difficult airway, which led them to refer a consult to ENT for tracheostomy. However, cross-consultations between the anesthesia team and ENT and the OMF, we decided and discussed that we needed to do a trial of an awake flexible intubation like this in here before we did the tracheostomy. So we also decided that pediatric ICU should be booked so that we nurse the child for any airway edema so that we reduce chances of taking them back for a tracheostomy. And we actually successfully avoided a tracheostomy and reduced the hospital stay. Our second presentation had subglottic stenosis and was referred to pediatric ENT due to 3 failed attempts at tracheostomy decannulation. This child had cerebral palsy and had a tracheostomy done due to prolonged intubation. He had had multiple intubations during his admission to the ICU, and the intubations were due to severe malaria and status dystonicus. He also had an NG tube for the last 6 months due to aspiration. So our problem list involved persistent airway obstruction and aspiration risk compounded with his neurological condition. Cross-consultations between the care team of neurologists, SLT, ENT, occupational therapists was both physical and via phone calls, and we decided to assess the swallow of the patient, get clearance for surgery interventions from the neurologist and the anesthesia team, and then to do a direct laryngoscopy, tracheoscopy, and bronchoscopy with intervention. And we found during this procedure that the patient had narrowing from the infraglottis down to the subglottic area, and the suprastomal airway was actually normal. And so we released the scar tissues and did balloon dilatation for this patient. Just so you can see down below where the tracheostomy comes out through. We eventually removed the tracheostomy tube and also removed the NG tube in this patient. Our third patient had tracheostenosis and presented with washing machine breathing since birth, had cyanosis, poor weight gain, and frequent lower respiratory tract infections. She was referred from cardiology following failed intubation to undertake surgery for an atrial septal defect and a ventricular septal defect. And cross consultations between ENT, CTS, cardiology was both physical and virtual. We decided to do a direct laryngoscopy, tracheoscopy, and bronchoscopy, and found a long segment tracheostenosis, as you can see in the video, and realizing that this child would actually need concurrent cardiac surgery and a slide tracheoplasty, we decided to defer any intervention. And we decided that it would be best to refer this patient to a center of excellence that would tackle both surgeries in one sitting. I hope we can appreciate the reduction in the trachea. The fourth patient had thoracocervical hemangioma with Kasabach-Merritt syndrome and presented with a large mass on the neck and anterior chest wall that was gradually increasing in size since birth. There was impending upper airway obstruction, and the child had an episode of spontaneous bleeding with severe thrombocytopenia. Additionally, the child had difficulty in feeding. Discussions with both medical and surgical specialist group were both physical and virtual, and we decided as a team to start the patient on propranolol and steroids, and later we used vincristine. We deferred any surgical procedures in view of the hematological crisis and canceled the patients about the poor prognosis. The palliative care team was very instrumental in doing this, and it is unfortunate as the mortality rate of the hemangiomas with Kasabach-Merritt syndrome are over 40%. So our patient unfortunately did not make it. So in summary, the complex aerodigestive or head and neck lesions that require many specialists, both medical and surgical, brought various techniques and skills that improved our patient care. So it reduced the hospital stay and it deferred potentially morbid procedures and improved the quality of life in our children. Multidisciplinary approaches are advantageous both to the patients and the specialists. And to the specialists, it enhances working relations with shared decision-making and interdisciplinary communication. With this talk, we invite you to community, to connection, to collaboration as we advance pediatric aerodigestive care together. Thank you for listening.
Hi, Lia, you're muted.
Sorry about that. Thank you, Fiona, for that wonderful introduction and really a good overview of how complex the patients that we see in this realm can be. I think on this call are folks from all over the world, and I'm sure we have a lot to share and collaborate and learn from each other in terms of different methods to approach these complex scenarios. I think our take-home message for this lecture series is hopefully to give to shed some light on how powerful multidisciplinary team management can be, and regardless of the state of a formal aerodigestive clinic versus just establishing communication across multiple specialties. I think that's one of our main take-homes from this entire series. So we'll have time for questions at the end. I'm going to jump into a little bit more on the nuts and bolts of how aerodigestive care works in my center in San Francisco, and try to elucidate some of the both the benefits and some of the challenges of this work that we all do. I think regarding questions, as they come up, you're welcome to include them in the chat, and at the end we can moderate and run through them between Fiona and I. Okay. So I have no disclosures. The objectives of my talk will be to talk a little bit more at an overview level of what aerodigestive clinical and surgical care can look like in a multidisciplinary setting, including how we set up clinic, some of the logistics behind that, some of the common clinical disorders that we see in our setting, and sort of the vast myriad of diagnoses that we treat as a group, and then focus a little bit more on the role of ENT surgeons in the aerodigestive setting. I'll specifically talk about, I think, what I'd consider sort of our keystone diagnostic procedure, laryngoscopy and bronchoscopy, which Fiona highlighted in her talk. But aerodigestive care is really the intersection of three realms of medicine. It's, upper airway, ear, nose, throat, pulmonology, the bringing in the lungs and the gastrointestinal system, and how those things interplay. And really, the diseases we're treating are sort of in the middle of these Venn circles here, where there is overlap, and how we can all collaborate to work together and treat patients. So who makes up aerodigestive clinic? This is not a hard and fast rule, and I think across many settings there are different ways to set this up. But in our setting specifically, I think the three sort of keystone pieces are a otolaryngologist, a pulmonologist, and a gastroenterologist, or a team of such providers. We also have a pediatric surgeon who we work with here at UCSF, and you'll be hearing from every member of these teams in the coming weeks. In addition, we have a speech-language pathologist or speech-language therapist, depending on where you're from, who is really integral in assessing children with complex swallowing and feeding issues, as well as a nutritionist. Many aerodigestive clinics have a dedicated social worker as well, because a lot of these kids have complex needs, as Fiona so highlighted. To support this effort, we have a dedicated clinical coordinator. So being able to harness all of these providers at once and arrange schedules and rooms and things, it really does require a bit of support staff if this is an ongoing and regular clinic. And then many teams also have a nursing component to help with some of the clinical pieces of care for these patients. And of course, the center point of this clinic are pediatric patients with complex feeding, swallowing, and airway concerns. So more specifically, who are we evaluating and treating in this clinic? It's children with really a myriad of pathologies that may be hard to diagnose or figure out the underlying causes for. So common things that we see are chronic cough, dysphagia and/or globus sensation, children with aspiration concerns or recurrent pneumonias that are unexplained, complex syndromes that impact the aerodigestive system, so things like charge syndrome, upper airway anomalies, esophageal and tracheobronchial anomalies. So Fiona again highlighted some of those, patients with complete tracheal rings, patients with tracheoesophageal fistulas. A number of our kids with tracheostomy come through our clinic, especially when they are pending decannulation because perhaps of other airway lesions that they have, and that we as a multidisciplinary team can help manage and optimize their care for prior to reconstructive surgery. We see a number of children with prolonged or frequent upper respiratory tract infections, and then it's sort of a slew of combined diagnoses, things including patients who have maybe at least two or more of the following: reflux, obstructive sleep apnea, reactive airway disease, stridor, failure to thrive, eosinophilic esophagitis, sialorrhea. Often there are other underlying comorbidities. And I think, given the broad audience, I am very aware that I am speaking from a sort of a Western or United States lens, and the pathologies that you see in your home setting may be vastly different and include things like malaria and the sequelae of that. So, this is going to be different depending on where you are in the world. So the way that our clinic is structured, or how it really works, is there's the clinic day that happens monthly, and then there's a lot of things that happen in the post-clinic period. So on the day of clinic, which is sort of highlighted by these three boxes here, we have a pre-clinic provider discussion where We are reviewing any new referrals made by external services, or sometimes as an ENT, I will refer one of my own patients to the clinic to be reviewed by my colleagues in other specialties. We'll also review any interval diagnostic workups that we have ordered on previous patients. The clinic day, it involves every single one of those providers that I mentioned, and we have options to do either in-person or telehealth visits. The video visits or telehealth is helpful, especially for some patients who have complex care needs, say they have a tracheostomy or a vent or other mobility issues, transportation issues. There are, if we don't need to do an in-person physical exam, especially on a first visit or a subsequent visit, then that has been a nice option to offer patients. But there are cases where we need to, it would benefit their care to be seen in person. So examples of that are when we do in-clinic procedures, things like flexible laryngoscopy, swallow studies will be, our next session is going to be led by our speech language therapist colleagues, and they'll talk more about specifics of swallow studies in the aerodigestive population. And other things like pulmonary function testing in the pulmonology landscape. So there are a number of reasons why having a patient come in can be really advantageous as well. On the same day, we also come back together as a group of providers to summarize a comprehensive team plan and then compile a letter or some form of communication to the patient so that they can see our synthesized plan and move forward with our recommendations. After the clinic, there are a number of referrals. Often these are complex kids, so we may be referring them to other services such as allergy, immunology, cardiothoracic surgery, genetics. So it's not inclusive to just or exclusive to just the folks on the aerodigestive team. One of the key diagnostic components is something called a triple scope exam. So that is really a triple endoscopy between ENT performing laryngoscopy and upper airway bronchoscopy, pulmonology performing lower bronchoscopy of the bronchial tree, and an upper GI endoscopy performed by our GI colleagues. So the same team members that are involved with assessing the clinic, the child on a clinic day are involved with a combined operating room day to save multiple trips to the OR and to maintain consistency with care and provider continuity. And then surgery can go beyond diagnostics, and depending on what the situation may be, there are a number of airway interventions that come out of patients referred through aerodigestive clinic, as well as GI procedures, things like G-tube placement and Nissen fundoplications, which we'll also cover in future lectures. And then after all of these diagnostics and potential procedures, we follow up and we see sort of how we've done as a team for these patients. So this is just a couple of examples. This is us doing flexible laryngoscopy in clinic, as many of you have, possibly have set up in your clinic. It's a very nice diagnostic tool, and it is possible to do it on kids with some parameters set, which is a sort of a lecture on itself. And this is just an example of a screenshot of our telehealth day, where we have a patient doing a swallows test with our speech language pathologist at their house. So a nurse and a family member, say, is actually there to in the home environment to help. We can do a lot of assessment over video visit if we're properly prepared for it. Other considerations about aerodigestive clinic or teams. So, Fiona had highlighted a number of these benefits that are well documented in the literature. But just to kind of re-emphasize some of those, I think this is an option to streamline care for complex patients and improve multidisciplinary communication, which I think the patients both witness, and we as a team, it can be a lot easier to really understand and diagnose and offer optimal treatment when you're all sitting in a room together or sitting on a Zoom call together. There's shared decision-making that comes out of this, and teamwork, and a real sense of collegiality and collaboration that can be built out of these structures. And I think that is, one of the biggest benefits of this. And as an ENT and someone, when we do pediatric training, we do 1 year on top of 5 years of non-pediatric surgical training. So I feel like through these opportunities, I've learned so much from my colleagues about how to be a better doctor for children by interfacing with colleagues in other specialties on a regular basis. So it's deeply fulfilling in that regard. There's the ability to coordinate procedures and avoid multiple trips to the OR, ideally lump, other diagnostic tests together. So if you have patients coming from far away, they can have all of their diagnostics kind of done and organized in a succinct way. And another big benefit for our field specifically is that this is a way to optimize care for complex airway surgery. So we're able to do a lot of preoperative assessment and adjustments that can then lead toward better success and outcomes for our more complicated airway patients by having them evaluated in an aerodigestive setting primarily. Some of the challenges, so, this is a big logistical and coordination challenge, and it can be quite time consuming. There can be issues with, where is this clinic going to be housed, and is it going to interfere with other provider schedules and other, other needs within a given, physical clinic setting. And coordinating this number of providers can be quite challenging as well. These visits can sometimes be overwhelming for patients to see so many providers in one go. It can be a bit confusing unless you're really cognizant of outlining plans and providing communication to patients afterwards. The visits can be much longer and the days can be longer. So I see far fewer patients on my aerodigestive clinic days than I do on a regular day. And so there are challenges with that, especially, I know many of you on the call have an enormous amount of patients. So there is a trade-off where the days can be and the visits can be longer and may take away from, seeing a high volume of patients. And then defining the patient population of who are we actually seeing in this clinic can be quite challenging. I think there's an option to have this serve more as a consultancy clinic where if patients are coming in with a referral for a specific issue, we treat them temporarily and then they kind of go back to a separate, what we call a medical home or, primary provider. There are some kids with complex needs and, whether the clinic functions more as a long-term care clinic is really a decision to be made amongst the team, in your own setting. It's sort of your decision to kind of define that, and it can be a bit challenging. And then I think the other thing to consider is, you could have kids who need to see 2 out of 3 of the primary physician providers or 4 out of 5 of the collective providers that are in the clinic. And so deciding how many issues a patient has that really qualifies them for the clinic is important as well. And I just include this slide to show that aerodigestive clinic is sort of the tip of the iceberg, at least in my institution. These are all of the other multidisciplinary clinics that I'm not personally involved with all of them, although I am involved with the first 3 that we have within ENT alone. So me and my colleagues here, almost all of us are involved with some level of multidisciplinary clinical care. And that is outside of the fact that, with the number of complex patients that we see, there is a lot of interim communication outside of these clinics as well. And I think Dr. Fiona had kind of highlighted that in her examples that even in the absence of a formal clinic, there is a lot of, there are a lot of ways where you can engage in a multidisciplinary fashion to benefit your patients. Okay, I'm going to speak a little bit about the main ENT procedure that we do in this to help with diagnosis and in some cases treatment of these patients. There are many airway interventions that we could spend full lectures talking about, but for now I wanted to focus on the triple scope exam and specifically laryngoscopy and bronchoscopy, which is the role that we as ENTs play in that combined multidisciplinary OR visit. Just to give an overview of other diagnostic and therapeutic procedures that we do in the context of this clinic. Sometimes, depending on the scenario, I might include a drug-induced sleep endoscopy to assess for sleep disordered breathing or obstructive sleep symptoms in children with aerodigestive issues. Interventions that we perform, sometimes in conjunction with our Laryngoscopy, bronchoscopy could include things like a supraglottoplasty, a laryngeal cleft injection for children who have aspiration risk or dysphagia, endoscopic dilation of tracheal or subglottic stenosis, which Fiona had highlighted earlier, in cases where that is not possible or not sufficient open airway reconstruction. And every single one of our children that undergoes open airway reconstruction comes through Aerodigestive Clinic to ensure that they are optimized from a pulmonary and gastroenterology standpoint, because things like reflux and things like untreated tracheitis or pneumonia can compromise the repair that you're doing in a reconstructed airway. And so having a multidisciplinary approach for these kids is really critical. And then sometimes there are other procedures that are not directly related to swallow per se, but things that we do commonly like adenotonsillectomy or other obstructive sleep apnea interventions that will pair with these trips to the OR. So in terms of laryngoscopy and bronchoscopy, the indications within the aerodigestive context are really to diagnose structural abnormalities underlying pathology of the upper airway and trachea. Some of these symptoms that we will take children for the OR for would be things like obstructive breathing, noisy breathing, aspiration, chronic cough, in some cases dysphagia. And some of the things that you can diagnose pretty effectively with laryngoscopy and bronchoscopy include malacia, so laryngeal malacia, tracheal and bronchomalacia. A laryngeal cleft is something that can be seen and contributory to some of the main diagnoses that I had mentioned. Tracheoesophageal fistula may be another. So those are just some examples. And yeah, in some cases, it's just a trip for diagnosis. But sometimes if there are sort of relatively straightforward treatments that we could tack on, such as endoscopic dilation of a stenosis, say, we could do that in the same go versus plan for a larger procedure based on this diagnostic look. And so this is an example of a suspension laryngoscopy. I'll talk a little bit about the nuts and bolts of how we perform laryngoscopy and bronchoscopy in my setting. And I think this is transferable to a lot of settings, even if you don't have the exact equipment. But to start with laryngoscopy, so for an good ENT laryngoscopy, it can be challenging to really see nuanced pathology if you don't have a good telescope. So in order to get a view with a good telescope or even a microscope, typically we'll use a Parsons or a Lindholm laryngoscope. These are some examples of that. With these, you're able to put a patient in suspension so that you can use both of your hands to operate. If you don't have these things, you can use a Miller's blade or an anesthesia blade. There are ways to do this effectively without having a lot of specialized equipment. So those are sort of the ways to directly look at the larynx. Sometimes we'll do a flexible laryngoscopy as well with a patient under sedation. This is how we perform a drug-induced sleep endoscopy, for example. And in terms of the scope, so what I mean by this, for those who may not have it in their home setting, so these are rigid telescopes, which we use to get a good view of the larynx and below. There are other instruments as well. This lower photo is showing a picture of a use of a microscope so that you can use both of your hands to operate, say, on the larynx or the subglottis without the help of a third hand or an assistant. So there are different ways to do this, but getting a really up close look at the larynx and below is really helpful in terms of treatment or developing a treatment plan. So when we are examining the airway, having the patient breathing on their own is important in many instances. So this is essentially required to assess for certain types of dynamic obstruction. So things like tracheomalacia or extrinsic compression from abnormal vasculature in the chest. You need a patient to be breathing on their own because you can actually miss these diagnoses if they're not moving. In some cases, vocal cord paralysis is another thing that you can see. I often try to assess this with a patient awake and talking or crying so that I can confirm whether or not vocal cord paralysis may be playing into issues with aspiration risk, for example. In order to do laryngoscopy, you need to do it typically without a tube in place. So having a way to passively ventilate the patient or deliver oxygen is helpful. We have an attachment to our laryngoscope so that you can ventilate through the laryngoscope itself. In other settings where you don't have that, you can easily just pop a endotracheal tube in the mouth that's being connected to the ventilator, and then they're getting some passive support while you're doing your exam. And this is important because a lot of kids who come through aerodigestive clinic or need to go to the operating room, say for foreign bodies or other things, are potentially compromised from a respiratory standpoint. So being prepared and knowing kind of what you need to be looking for in advance is really helpful. And then to that last point, having a mask to ventilate the patient, having endotracheal tubes ready to intermittently intubate the patient if they need more support are also quite important. These are some other sort of safety things that I always have present. This top is topical lidocaine, which we can place on the vocal cords with a little injection syringe, and what that does is it topicalizes and anesthetizes the vocal cords to prevent a laryngospasm when you look through the vocal cords. Being prepared to mask ventilate the patient yourself. This is a really important area. We include a talk from anesthesiologists in this series because when we are working on the airway, that communication between anesthesiology and ENT is really, really critical. And then this is an example of placing an endotracheal tube over a 0-degree telescope, so that when I'm doing my exam, if I have a patient who's very tenuous from a respiratory standpoint, I can actually just pass the endotracheal tube while I'm looking at their airway, confirm that it's in their airway, come out with my telescope and give them some breaths. So this is one way to more safely approach airway procedures. Bronchoscopy. So this is really talking about assessment of the areas below the vocal cords or the subglottis, the trachea and the bronchial tree, the bronchoscope type. So, the telescope that I had mentioned is one way to do it. And I'd say this is sort of my workhorse when I'm doing a quick exam. I'm often using a telescope with laryngoscopy and sometimes with suspension, putting the patient on suspension so that I can use two hands if needed for interventions. We also have rigid bronchoscopy, which a number of you I know have or use for things like airway foreign bodies. This can be used in a diagnostic capacity too, and it allows you to simultaneously ventilate the patient. So this is, if you have a patient who's really tenuous, this is a great option. And then we work with our colleagues in pulmonology to do a flexible bronchoscopy. So you'll hear all about this part of it, but this is when we talk about the triple scope, there's really the ENT bronchoscopy as well as a pulmonology bronchoscopy to assess the lower airways. And they have, in my setting at least, they have more equipment to do that effectively. So they do that, and they do a number of associated diagnostic tests. Some photos of laryngoscopy. So these are all things that you may see in the context of a diagnostic workup for children with aerodigestive issues. The first is just demonstrating how we perform a vocal cord injection for children with a vocal cord paralysis. So you see the injection needle coming in here. This top right corner is laryngeal papillomatosis. We're seeing far less of this now that HPV vaccination is fairly accessible in the United States, but I know globally this is still a big problem. This lower left hand corner is an example of laryngomalacia. You can really see this omega-shaped epiglottis and these tight areorytenoid folds. So you can put a patient on suspension and address this with this procedure. And then this photo here is an example of a laryngeal cleft that's being repaired with a laser procedure. So with a laryngeal cleft, you have a deep groove between the arytenoids that can sometimes go deeper than the vocal cords and allow passage of liquid when children are eating. And that can be a cause of chronic cough, of recurrent pneumonias. Sometimes it exacerbates things like recurrent croup. So we check for this when we do laryngoscopy, and then there are different ways to repair it. One is to do a laser procedure and throw some suture, but there are other ways that don't require a laser to do this. Bronchoscopy, so assessment of the tracheal airway and below. This is an example here on the top left of subglottic stenosis, pretty significant. You can see there's basically like a pinpoint, a little bit bigger than a pinpoint airway. Fiona had mentioned a really good example of lysing that. This is a suprastomal granuloma. So below here is a tracheostomy. And in order to safely decannulate a kid, this is something that you can pretty easily take out with an endoscopic intervention and allow a child to decannulate. So having a good view of the airway can help do that. And this is an example of dynamic collapse. So of tracheomalacia, where you see with inspiration, things are nice and open. You can see the carina, but with expiration, you see everything flattened. So when I mentioned that having a child breathing on their own is really important, not having them paralyzed for this procedure, this is a really critical component to doing these exams well, and having a really, confident anesthesiologist who can help to do this and do it safely is also important. And we'll, as I said, get into more of this in future lectures, but you can miss this because if you have a patient who's too sedated, it can just look sort of open and as if there's no problem. And then you're sort of left wondering like, well, what is going on here if you don't sort of have them sedated appropriately for this exam. So I've mentioned some of this already, but I think with this procedure, preparation and teamwork is really key to airway surgery. This includes the pre-op workup, and I think highlights why having an aerodigestive clinic can be really helpful and really optimal for patients. Beforehand, if you have access to a flexible laryngoscope, then you're able to look and diagnose some pathology right away so that you go into the operating room knowing what you're dealing with. I know that's not possible in all settings, but it is something where it's a very, very useful tool. And if I had to advocate for something in a clinical setting, I would say a flexible laryngoscope is really quite important if you are, treating a lot of airway pathology. A swallow study. So we'll hear from our speech language pathologist next week about about a fees and other mechanisms of assessing for dysphagia and aspiration. Considering imaging. So as I mentioned, a number of these kids are quite, can be quite sick. And so knowing what their lung parenchyma looks like, knowing if they have vascular anomalies that may be compressing their trachea can be helpful in certain scenarios. And so some of the imaging that we might do very simply is a chest X-ray, in some cases a chest CT, if there's access to that. I always tell my residents to visualize the steps of a case ahead of time. So this may be very obvious, but I think especially with airway surgery, when things can change really rapidly and it can be dangerous for patients, it's important to go in knowing, sort of visualizing in your mind what you might do within the context of a case, discussing the plan with the anesthesia colleagues. So when I do these procedures, I actually tend to work with specific anesthesiologists if I know that it's going to be a more challenging airway. There are some anesthesiologists who have, either had more specific training. If you have a pediatric trained anesthesiologist or somebody who does a lot of airway procedures, trying to identify who to work with is really critical. These are not cases for people who are new to training, especially, I know there's a lot of CRNAs, some are very excellent, but making sure that you're identifying colleagues who are really strong with being able to handle more tenuous patients, especially those with airway conditions, is a really key piece of safety advice that I would give. Being in close communication with your scrub team. So again, these are cases where sometimes you need to move very quickly. So having people paying attention, not having too much noise in the room. I know a lot of settings, there's a lot of trainees in the room and that's fine, but this is one where I'm pretty hard line about keeping the room quiet because I need to be able to communicate with my scrub team, with the anesthesiologists, with my, resident, whomever I might be working with, so that we can move quickly if needed. Always check your own setup. There's a lot of equipment that goes into this. So again, visualizing what you do ahead of time and knowing that you have every single piece of equipment that you need is really important for these cases. And then being prepared for worst case scenarios. So things like laryngospasm, things like complicated airways that you may know about in advance. You know, Fiona had mentioned an example of that with her first case where you have a big mandibular mass. You know you're going to have a challenge to intubate that patient. So planning ahead is really important. How to control bleeding. So there are a number of ways to control bleeding. You know, adrenaline on a pledget that you can take in and out of the airway with a device is one way to do it. There are a number of other mechanisms that you can use to help control minor or even major airway bleeding in the case of a bad scenario. But having a strong suction, I can't emphasize enough that that's really important to have with these cases, because that alone can be a life-saving measure. So these take time and preparation. And that's really all I had for today. This is one of my patients who, had a tracheostomy for many, many days, about 1,000 plus, and was a patient in an aerodigestive clinic, and through coordinated care with our multidisciplinary team was able to have her trach out finally. So these are the kind of children that we're treating, and yeah, I hope this has been helpful. I think we have some questions here and about 10 minutes left in our lecture to address questions. And feel free to include any questions in the chat. I don't think we have the ability to ask questions live. Dulcie, is that right?
People should be able to unmute themselves if they would like to ask questions.
Thank you, Lia, for the beautiful presentation. The face of the kid is extremely cute. And I also had one of the patients who was very excited about having the trach out. We don't have any questions in the chat yet, but I did have one question for you, Lia. So in a setting, for example, in my setting, we don't have pediatric bronchoscopes available yet. Would you, in your capacity as an ENT, use a flexible scope to do a bronchoscopy that would be as if a pulmonologist's bronchoscope?
Yes, I think that there is still, I think use what you can, and looking with a flexible bronchoscope is going to give you a better view, say, than just looking with your eyes, right? How are you doing foreign body retrieval?
So for foreign bodies, we use rigid. We use the rigid bronchoscopes, and most of the times we actually have to wing it. We don't really have the telescopes. Most centers don't have the telescopes to visualize in an endoscope. So you actually have to use naked eye to keep looking. But that would give you only up to maybe the first main or the second main bronchus.
Yes, I mean, yeah, I know this is a big challenge. And so I think a couple of, so number one, like, yes, if you have a flexible bronchoscope, like, absolutely, you can use it. It can be challenging to put it like through a rigid bronchoscope. I think this is an area where advocacy is really important, to give just a bird's eye view on my view on sort of pediatric care globally. We just put in recommendations with the Global Initiative for Children's Surgery that is putting together big guidelines for global access or improvement to pediatric surgery care. And that was one of my asks, is that every center who has a trained person capable of doing these exams has access to a rigid telescope. There are some large organizations that are, I think, working on this effort, and this is an area of advocacy for all of us, all of you in a setting where you don't have something like this. Kids OR, if you have a kids OR, they're putting together critical airway packages, and that may be something that is available if you already have an established kids OR in your center. So this is I'm going on a bit of a tangent here, but I think not just for aerodigestive, kind of nuanced aerodigestive care, but for the basics of saving lives and doing, many folks I know see a lot of foreign body, and being able to do that with an optical forceps or a longer telescope. I will say, in my experience working in Tanzania early on at Bugando Medical Center, there was a telescope that was used, I think, in the urologic setting that was quite long and could be used as a bronchoscope. So another area in multidisciplinary care is to talk to your colleagues in other fields of surgery, and if needed and if possible, and if people are willing to share equipment, if it can be done safely, you know, there's a lot of cross care, I think, that can be used with equipment across different specialties. And even for things like foreign bodies, like I will use vascular catheters from time to time to balloon and pull out a foreign body. And that's something that I wouldn't know about unless I had talked to colleagues in other surgical fields. So I would encourage that of everyone as well to get creative in times of challenge. And I know it's hard for a lot of people. Did that answer your question, Fiona?
Yes, it did. Thank you. We have a question in the chat. How many percentage of children have laryngobronchial obstructive? Well, in general or in your clinic, what is the most common age you find the problem? This is from Davy.
Hi, Debbie. Our answers are probably different, Fiona, across our different centers. It's, you know, I work at a tertiary care center, so I work at a center that covers a lot of my entire state, my entire region. And so I would, and I mean, this question could mean a lot of different things. I think if you're talking about specifically obstruction of the, you know, trachea, I probably see more than average because I treat far more kids with tracheostomies, say, or for me personally, I would say it's still only, it's less than 20% of my practice as a pediatric ENT. There's far more other things that I'm seeing in my general clinic, and most of these are coming through my more complex clinics. But I think that this, you know, in other settings, this can happen due to prolonged intubations or intubations with the wrong sized endotracheal tubes. There's a lot of iatrogenic trauma that can lead to airway stenosis. And so when I'm working with colleagues overseas, I've seen a lot more of that. And Fiona, you can corroborate this. Also massive tumors, things that, but yeah, in terms of a percentage, Fiona, what would you say for your practice?
For our practice, I also work in a tertiary center. So we see about 1,500 children monthly, perhaps. I hope I haven't really, Dr. Amina is on the call. But we see around about between 1,000 and 1,500 children in our pediatric clinic. And of those, I could say that potentially 20 to 30 might actually have some sort of obstructive lesion. But that being said, I am not including the foreign bodies. I'm really not including the foreign bodies. I'm talking about other lesions that could be due to congenital or, like you said, iatrogenic from the intubations, the traumatic intubations or the prolonged intubations and tracheostomies. So it's still not a very huge thing that you will see generally in the clinic, but it's just complex. And because it's complex, you need to, it takes up a lot of your time and effort, and lots of things get into the complex airway. So I think it's, because he said in general in your clinic, and the commonest age group in our setting seems to be less than 5. So children under 5 years of age are the ones who we tend to see. Over the last couple of years, it's been mostly 2 years old and below that will come in, maybe intubated for epilepsy or something. And those are the ones that I've been seeing in my practice. I hope that answers your question, Davy. I don't know if we got what you had asked.
I see a question embedded in a comment from Esther above Davi. And, you know, and I think, I don't know, Fiona, if you could address this in your setting, you know, if for folks that don't have a lot of access to diagnostic tools or a formalized multidisciplinary team, swallow studies, flexible bronchs, I think there's a question about safe tips on how to improvise. And anyone, please feel free to chime in on this. If there are things that we talked about today that you're like, well, we don't have what you're talking about, but this is what we do, I think this would be a really great forum to share that knowledge. And so feel free to include in the chat, what all you've been able to accomplish in this area or improvise on. But yeah, Fiona, any thoughts on that?
Thank you, Dr. Esther. I think so. Dr. Esther is one of the people that I've actually been working closely with. I hope it's actually Dr. Esther Nakasaga, and we've had lots of challenges together, and we've been doing lots of things. The unfortunate thing is that we have to wing it with our own equipment. So we've been going through series of buying our own endoscopes or pushing for the equipment to be gotten through the hospital, and sometimes because of procurement challenges they really delay. But this is actually one of the things that got me into CHESA. So CHESA, for those who don't know, CHESA is Center for Health Equity in Surgery and Anesthesia, and it's a platform that can give you a chance to talk or to learn how to express yourself so that you can know how to advocate for better care. And for me, this was the starting point, because I got really frustrated in trying to realize care for the setting, for the children in my setting. And one of the things that I've been learning is that we have to do lots of talking, lots of advocating, and lots of collaboration. So through the collaborations, we've been able to get a few people bring us a pediatric flexible laryngoscope, not through the hospital, but really through friendships that you meet at different spaces and while you're talking and they come in. And I'm happy to let you know, Lia, that the Kids OR actually did help us setting up with newer equipment for bronchoscopy equipment in Molago, which is a big boost for us. So for me, lots of things like talking and getting people to know that we actually have these challenges, and then having to come across to help us. But the other things that we've been doing to like you said, like you ably said, at the beginning, we didn't have an endoscopic tower, but pediatric surgery had an endoscopic tower. So we did talk to the pediatric surgery team, and they would lend us their tower. And so we're actually able to do that. It's not that is really not improvising, but it's trying to work within the same means that we can get that going. For the flexible bronchoscopes, we still had some donations from one of our visiting lecturers, Prof. Roland, who brought us a flexible laryngoscope. So that's what we've been using in the clinics. Other things that I fear to say on air are just reusing some of the atomizers, reusing some of the bronchoscopes. The cardiac surgeons do use some of the of the balloon dilators. So we reuse some of those balloon dilators. And generally, it's really doing what is best in a safer way. So you do have to be a bit more careful about that. That being said, I heard you talk about safety, because the equipment is quite fragile, and we do have to hold it with utmost care, and even sometimes be a little bit selfish and not leave it behind for people who might not know how important the tools are for us to use. But we do take it by case-by-case basis on what we need. And most of the times, if we're going to improvise with something new, then we try it in the lab with some animal specimen. So you try something to see if it would work, and so that you don't really faff. But the other thing that we do is just wait for someone else who would understand the implications of the kind of surgery that you're going to undertake. And I'm not worried to talk about this in this place, that if I think that the surgery is beyond what I can handle, for example, I may know how to do a slight tracheoplasty, but I need a team effort. I need proper ICU care. I need cardiothoracic. We need a bigger team than is available. Then it's best for the patient's safety to send them to a center that is actually capable of having better outcomes for this surgeon, rather for this patient. So it's not that we throw in the towel, it's that we think about the patient's safety, we think about what we have at hand, and then we advocate for better care, for better systems. And we also just kind of have these talks going so that people get to know that this is actually what we deal with in our spaces. Sorry, I've talked on for so long. I hope I have answered your question, Esther, or your concern.
Yeah, that was great, Fiona. I think that last piece about you know, we can only accomplish what we can accomplish, and not being overly prideful about it, and sending a patient to the best possible scenario when we have the means to do that. We do that too. I'll send patients to Cincinnati. We have a kid with full laryngeal atresia, and I think it's just beyond what we can really offer in terms of an optimal outcome here. And so, yeah, knowing that there is a time to act and a time to rely on others or to make asks of others is a very appropriate and humbling part of our job that I think is important to destigmatize. We have a question from Dr. I'm so sorry if I say your name wrong, Wanile Makane. For diagnostic and therapeutic suspension laryngoscopy, do you routinely keep these kids intubated post-op? And if not, do you perhaps use steroids, PPIs, et cetera? Great point, and something I forgot to bring up in my talk. I would say the vast majority of the time, I am not keeping kids intubated after intervention. I think my thoughts on that are like, if I am going in for an air obstruction, my goal is trying to alleviate it and give them a better airway. That said, I am manipulating an airway, and it can cause, that can cause negative sequelae or complications, including things like more scarring. And so I do always put my patients on steroids, at least for 24 hours post-op. I'll do IV Decadron during the case, and then if I'm going to watch them overnight, then two more doses. If I'm just doing a diagnostic look, I don't always feel strongly about doing that. But if I'm doing any sort of manipulation to the airway, or say the view is very challenging, sometimes kids are very challenging to get a good view, and I'm going to cause some swelling of the glottis or the supraglottis just by doing the diagnosis, I will give them steroids and watch them. I'll put them on CPO or continuous pulse ox monitoring. So that's the other thing that we didn't really touch on in this is, having a recovery, perioperative recovery area or a PACU that has one-on-one nursing and has, at least continuous pulse ox, but ideally the ability to monitor, all of the vital signs is really critical. If you have the ability to keep them, you use your best judgment on these, and not every kid is going to need to have this higher level of care. But I do think in the immediate postoperative period, that is quite important. I mean, even with something like an adenotonsillectomy, you could have kids die in the post-op if people are not watching them, because they can still obstruct from being overly sedated. So these are, very preventable areas of mortality that I think you do have to think about and advocate for as an airway surgeon, even if you're just doing adenotonsillectomy. PPIs, it depends on the scenario. So for sure, pre-operatively for intervention, part of the reason we do the triple scope may be to diagnose or to assess for reflux, or the efficacy of, say, a PPI that's been started. I don't like to keep kids on PPIs long term. There is some data to suggest that there's some negative sequelae from that. But in a short period, especially if I'm going to do a lot of airway surgery and I have a clinical picture of reflux, there are cases where I will do that. So these are both really great points to bring up. And Fiona, if I missed anything to add on that?
No, that is similar. Just a follow-up question from what you said. Do you give PPIs before the surgery? And also, do you routinely consent for an endoscopic intervention at the same setting, or would you come out and tell the patients that this is what you're going to do? Is there a blanket for that?
Great question. I will often rely on my preoperative flexible laryngoscopy. So say I know a patient has laryngomalacia. In my treatment algorithm for that, before I even bring them to the OR, I may trial, if it's a kid who has a lot of reflux, has a lot of spitting up of milk, we might try some conservative interventions first, put them on a PPI second, and then if they continue to have, say, extreme stridor, failure to thrive, et cetera, then we're doing the operating, so the bronch and the supraglottoplasty at the same time. I'll often talk to parents ahead of time about possibles. So I don't put everything on that possibles list, but I will talk to them about a laryngeal cleft injection. I'll talk to them about stenosis, given the clinical setting. So again, I'm using sort of like my clinical judgment on the situation to think through some of the possibles. But anything beyond that, I tell them, this is diagnostic, and we would need to kind of come back. For PPIs, besides, I think if you know that there's stenosis there, it's reasonable to put them on that, because I think that any insult or things that can cause more inflammation could mean that your resulting dilation may not go as well. So I tend on the more aggressive side, I guess, with that. Not everyone will agree with that. But especially leading up to airway reconstruction, we've been pretty rigorous about treating them preoperatively with PPI, sometimes with something like azithromycin, and if we don't, we'll try to culture if we have a trach, a kid with a trach, and try to do directed antibiosis leading up to surgery so that we can optimize our graft repair. So yeah, it's not a hard and fast rule for everything. It's sort of case dependent.
Thank you, Lia. I don't see any more questions in the chat. Just out of curiosity, which specialist group generally sends the most patients to you?
To me, for like aerodigestive?
Yes.
I would say we actually tend to sort of self-refer, meaning that like a primary care doctor may refer to pulmonology and for chronic cough, say, and then our pulmonologist will maybe do some baseline treatment, but then send over to us as a group if they've identified other things, or say we in our system, we can get triggered, like where you see that a patient's been referred to ENT, pulmonology, they also separately see GI. So sometimes we can, when we're reviewing the referrals, we can flag these patients and put them in. We do have a list of diagnoses that are sort of like possible diagnoses to go into ADC. So our schedulers will look at that and say, oh, is this an ADC patient? And so yeah, I would say pulmonology is probably our biggest customer. They see a ton of patients for various respiratory issues. And since we work so closely together on trach children, on kids with other voice and swallow issues, I think we have just close collaboration to begin with. So they're probably our biggest referral base.
Thank you.
All right. Well, I think we can wrap up here. Dulcie, our coordinator, first of all, a big shout out to Dulcie, who's been helpful in putting all of this together, and Fiona for being amazing and being the impetus for all of this and all of the important coordination that's gone into this. We apologize for those of you that had the time wrong. It's going to be at 7 p.m. East African time. So we have a time change coming up. We're going to try and keep the East African time consistent. So yeah, please pass along to any colleagues that might have been confused about it. We'll make the recording available to everyone who had registered, and make sure to try to communicate the correct time, which is 7 p.m. So thank you all for coming, and yeah, we'll see you in a couple weeks.
In 2 weeks. Thank you, everybody.